Usually when we talk about a medical diagnosis, there's this expectation of precision, like engineering.
Right. Yeah, like it's a math problem.
Exactly. You break your arm, the x-ray shows that jagged white line, and the doctor just points and says, well, there it is. But when pain doesn't show up on a scan, it almost always gets dismissed.
Oh, constantly. It is the absolute definition of diagnostic muddy waters.
It really is. And today, we are diving into the microscopic, just agonizing reality of a condition called NPV. And we're asking whether a buzzy, blood-spinning wellness trend, the O-shot is a miracle cure, or, the equivalent of throwing gasoline on a fire.
Yeah, and to really understand what is happening to patients who suffer from this, we are pulling from some incredibly detailed literature today. We're looking at clinical trials in the Journal of the American Academy of Dermatology, some peer-reviewed research from the journal Toxins, and clinic data on regenerative gynecology.
So our mission for this deep dive is clear. We need to unpack the intense, hidden biology behind why some women experience debilitating pain in this one specific area.
Yeah. Right, we have to look at the cellular level first.
And then we want to look at how traditional medicine tackles it. And finally, figure out the therapeutic approach for using the O-shot. Because, this is a treatment explicitly designed to increase nerve sensitivity.
Which is a huge issue here.
Yeah, it poses a massive biological paradox when you're dealing with a condition that is literally defined by having way too many nerves.
Exactly. And to understand that paradox, we really first have to understand the sheer agony of what having, too many nerves actually looks like under a microscope.
Okay, let's unpack this. We need to define some terms for you. First, there's vestibulodynia, which broadly means chronic pain in the vulvar vestibule, so the area right at the opening of the vagina.
Right.
But we are drilling down into a highly localized, specific subtype today, which is neuroproliferative vestibulodynia, or NPV. And the data here is just staggering.
It really is. Clinical pathology shows that patients with NPV have up to 10 times the density of C. afferent nociceptors in their vestibular tissue compared to people without the condition. 10 times. That's wild. But we should probably clarify what a C. afferent nociceptor actually is, right?
Yeah, definitely, because not all nerves do the same job. Some nerves sense a change in temperature, some sense a soft touch. C. afferent nociceptors do not care about a soft touch.
Right.
These specific nerve fibers are your body's dedicated, unfiltered pain communicators. Their entire job, literally their only function, is to detect potential tissue damage and just scream, ouch, to your central nervous system.
Wait, really? So they aren't sensing temperature or friction at all? Their only job is pain?
Pure pain signaling, that is it.
Oh, wow. So to put that in perspective for you, it's like your body installed this hypersensitive home security system where the alarm blares at 120 decibels just because, a speck of dust floated by instead of an actual burglar.
Yeah, that's a highly accurate way to visualize it. You basically have 10 times the number of alarms, all wired to detect nothing but pain, packed into one tiny, highly sensitive millimeter of tissue.
Just a millimeter. God, that sounds awful.
Yeah.
It's agonizing. And what's fascinating here is why this happens. Because biology is usually incredibly efficient, Nerves don't just randomly decide to multiply by a factor of 10 without a specific command.
Well, what's giving the command?
Well, the research points to a localized cellular misunderstanding. It begins with local inflammation. But this inflammation triggers the local immune cells to start producing a peptide called angiotensin II.
Hold on, angiotensin.
Yeah.
Isn't that the system doctors talk about when you have high blood pressure?
It is, yeah. Most people know the renin-angiotensin system for its role in regulating blood pressure throughout the whole cardiovascular system.
Right.
But here, the body goes totally rogue. It establishes a local renin-angiotensin system right there in the vestibular tissue.
Wait, locally? In the
Yeah.
pelvis?
Exactly. The local immune cells, specifically the T cells and macrophages that usually just, fight off infections, they actually start expressing the proteins needed to manufacture this blood pressure peptide.
So the immune cells are moonlighting.
Yeah.
They're building a system they have absolutely no business building in that tissue.
Right. You get this localized buildup of angiotensin II, and this peptide starts binding to specific receptors on the local nerves called AT2 receptors.
Okay. And what happens when it binds?
Well, it doesn't just sit there. It literally acts as a powerful fertilizer. It forces what researchers call abnormal nociceptor axon proliferation.
Meaning it grows more nerves.
Exactly. It commands the pain nerves to sprout, branch out, and multiply just uncontrollably.
So a localized immune response is accidentally tricking the body into growing a dense web of pain sensors.
Yeah, that's exactly what's happening.
So if a patient is dealing with this, how does a clinician even diagnose it? I mean, you can't see a microscopic web of nerves with the naked eye. And I'm assuming it won't show up on a standard pelvic ultrasound.
No, it won't. Clinicians have to rely on a highly specific physical exam. They're looking for what the medical literature calls Friedrich's 3 criteria.
Okay, what's the first one?
The first criterion is exquisite tenderness when the vestibule is touched with something as soft as a moist cotton swab.
Which makes complete sense now that we know about the nociceptors. I mean, if you have 10 times the pain alarms, a cotton swab isn't a soft touch anymore. It probably feels like a knife.
Yeah, patients frequently describe it as a severe burning or tearing pain from just that tiny amount of pressure.
That's horrifying.
And, the psychological toll of that alone is immense because the level of pain does not match the physical stimulus, which often leads to patients being told, it's all in their head.
Right, which we hear so often in women's health.
Yeah.
And what are the other two criteria?
So the second is vestibular erythema, which is a visible localized redness.
So the tissue actually looks inflamed.
Yeah, the tissue is literally inflamed, often specifically located at the openings of the major and minor glands in the area.
Okay.
And the third.
The third is a history of severe pain with any attempted vaginal entry, whether that's a tampon, a medical speculum during an exam, or intercourse. And the medical literature breaks this down even further, right, into two distinct categories,
Okay.
congenital and acquired.
Yes, that's right.
Meaning, you can either be born with this hyperinnervation or your body can suddenly trigger it later in life.
Exactly. Congenital, or primary NPV, means the nerve overgrowth has likely been present since birth. These patients typically report that the agonizing pain has been there since their very first attempt to use a tampon.
The tissue is just always miswired.
Yeah, exactly.
Okay, this is the part of the research that I really need you to explain because when I read it, I literally had to double-check my notes.
The belly button thing.
Yes. The clinical data links congenital NPV to umbilical hypersensitivity. The belly button. How on earth does a pelvic pain condition connect to the belly button?
I know, it sounds bizarre, but it is this brilliant piece of embryological detective work. We have to go all the way back to fetal development in the womb.
Okay, I'm with you.
The tissue that eventually forms the umbilicus, your belly button, and the tissue that forms the vulvar vestibule actually originate from the exact same embryonic cell line. It's known as the urogenital sinus.
Oh, wow. So they're essentially twin tissues.
Exactly. As the fetus develops, those cells migrate to different parts of the body. But if there is a genetic programming error in that specific cell line early on, an error that causes too many nerves to grow, that error gets carried to both locations.
That is wild.
Right. So a patient with congenital NPV often has the exact same abnormal nerve overgrowth right inside their belly button, making it hypersensitive to touch as well.
That is just astonishing.
Yeah.
A tiny genetic typo in the womb dictates a localized pain response decades later in two completely different parts of the body.
Yeah, it really highlights how interconnected our development is.
It really does. But what about the patients who weren't born with it, the acquired or secondary NPV group?
With acquired NPV, the patient had a period of completely normal, pain-free function. They could use tampons or have intercourse without any issue, but then the neuroproliferation is triggered later.
What triggers it?
Well, the clinical data notes this frequently happens after a severe allergic reaction in the pelvic region or after a prolonged battle with chronic recurrent yeast infections.
Okay, let me guess. The yeast infections bring the immune cells to the area.
You've got it. The chronic immune response to the infection, or the allergy, floods the area with those T cells and macrophages.
And normally they'd just leave once the infection is gone.
Right, but for some reason in these patients, those immune cells don't just fight the infection and leave. They stick around, kick that local renin-angiotensin system into overdrive, and start dumping that nerve fertilizer onto the tissue.
Sparking the nerve sprouting.
Exactly.
So if a patient's body is essentially stuck producing this nerve fertilizer on a constant loop, how does a doctor even begin to shut that down without harming the surrounding tissue?
It's difficult.
Yeah. Which brings us to how medicine actually tries to fix this, moving up the traditional treatment ladder.
And what's fascinating here is how deliberate the stepwise approach has to be. Since the root of the problem is hypersensitivity and hyperinnervation, the therapeutic goal is pretty clear-cut.
Right.
We have to either calm the nerves down so they stop firing, or we have to remove them entirely.
So let's start at the bottom of the ladder, the less invasive options.
First-line treatments often involve highly concentrated topical numbing creams to try and break the pain cycle. A common approach is a 5% lidocaine ointment applied generously to the vestibule and left on overnight.
Overnight. Numbing creams usually wear off in an hour at the dentist. Why are they leaving it on for 8 hours?
Because the goal isn't just temporary relief so the patient can get through the day. By keeping the nerves continuously numbed for an extended, unbroken period, the doctor is trying to interrupt the constant pain feedback loops being sent to the brain.
Oh, I see.
Think of it like rebooting a frozen computer. You are trying to convince the central nervous system to stop being on permanent high alert.
That makes a lot of sense. And alongside the topicals, they use oral medications too, right?
Yes, systemic nerve pain medications. Drugs like amitriptyline, which is a tricyclic antidepressant, or gabapentin, an anticonvulsant.
But those don't cure the extra nerves, do they?
No, they don't cure or remove them. Instead, they work chemically to raise the threshold at which the nerves fire. They make it harder for the alarm system to be tripped by that speck of dust we talked about earlier.
Right. But if rebooting the system and raising the threshold doesn't work, the latter gets more intense.
Yes, it does.
The literature goes into detail about targeted injections, specifically using Botox or incobotulinum toxin A. Now, most people hear Botox and think of cosmetic clinics smoothing out forehead wrinkles.
Naturally, yeah.
So what exactly is a wrinkle relaxer doing for a web of hyperactive pain nerves?
Well, it's actually a highly versatile, powerful neurotoxin. In a clinical setting for NTV, a specialist might perform a 200-unit submucosal injection of Botox directly into the targeted painful points around the vestibule.
That sounds intense.
It is. Now, part of what it does is what you'd expect. It paralyzes and relaxes hyperactive pelvic floor muscles. When a patient is in chronic pelvic pain, their muscles often spasm involuntarily to protect the area, which just creates more pain. So Botox stops the spasm.
Okay, muscle relaxation makes sense, but does it do anything to the nerves themselves?
That is the crucial mechanism for NPV. Botox actually blocks the release of specific pain-signaling neuropeptides from the nerve endings. The two major players here are substance P and GABA.
Wait, stop there, because we need to explain what those actually are. What is substance P?
Substance P is literally the messenger molecule. It is the chemical that the nerve ending spits out to tell the surrounding tissue and the brain, hey, we are experiencing severe pain and inflammation.
Okay, got it.
If the nerve is a person shouting into a microphone, substance P is the sound traveling through the wire. By inhibiting its release, Botox essentially cuts the microphone cord. The nerve might still be trying to shout, but the message never reaches the brain.
That is a brilliant mechanism. So the extra nerves are physically still there, but they've been chemically gagged.
That's a great way to put it, yeah.
But that raises a really critical question for me. If this condition is caused by a literal physical overgrowth of nerves, do the numbing creams, the gabapentin or the Botox, actually get rid of the extra nerves?
No, they do not. And that is the hardest reality of this condition. They just silence them. The physical 10x nerve density remains in the tissue.
So the hardware is still there.
Yes. For many patients, silencing them is enough to restore their quality of life. But for severe refractory cases, meaning cases that simply do not respond to any of these medications or injections, which is incredibly common with the congenital form of NPV silencing, isn't enough. The alarm is just too loud.
Which leads us to the very top of the treatment ladder, the absolute last resort.
Right. The surgical resort. The gold standard cure for these severe refractory cases is a surgical procedure called a vestibulectomy.
And a vestibulectomy is an excision surgery to physically remove the over-innervated tissue.
Exactly.
So if you have 10 times too many pain nerves in a piece of skin and no chemical will quiet them down, a surgeon goes in and carefully removes that specific millimeter-thin layer of vestibular mucosa where those nerves live.
It is a major surgical step.
Yeah, but the clinical data notes it can be deeply curative for the right candidate, right? Because it physically removed the hardware of the alarm system.
Exactly. It directly addresses the anatomical root of the problem when nothing else can.
So we've established the biological reality of NPV, and we understand the traditional medical ladder, which is entirely focused on calming or cutting out these extra nerves.
Right.
Here's where it gets really interesting, because there's a completely different approach to genital health that you have almost certainly seen heavily marketed at wellness clinics or in lifestyle magazines. I'm talking about the O shot.
Ah, yes, the orgasm shot. This pivots us away from traditional pain management and entirely into the field of regenerative medicine.
Let's break down the mechanics of what this procedure actually is, because it honestly sounds like science fiction.
It kind of does.
Based on the clinical protocols, it's an in-office procedure. A clinician draws about 15 cc of your own blood from your arm, just like a routine physical. Then they put that vial of blood into a centrifuge, and the protocol specifies spinning it at around 2,850 RPM for exactly 9 minutes.
The precision of that spin is crucial because it separates the components of the blood purely by density.
Right. It's like taking a bottle of raw, unhomogenized milk and spinning it incredibly fast until all the heavy cream separates and gathers at the top.
Exactly.
Except here, they discard the top 80%, which is platelet-poor plasma. The remaining 20% at the bottom is the target platelet-rich plasma, or PRP.
And platelets are essentially your body's cellular first responders for tissue healing. They're absolutely packed with growth factors.
Like when you get a cut.
Yeah, when you accidentally cut your finger in the kitchen, platelets rush to the scene, clot the blood to stop the bleeding, and immediately release these growth factors to stimulate new blood vessels, produce new collagen, and build new tissue to heal the wound.
So in this procedure, the doctor extracts this super concentrated PRP, applies a numbing cream to the patient, and then injects this plasma directly back into the clitoris and the anterior vaginal wall.
Yes, that's the protocol.
And the marketed benefits are huge. Clinics claim it stimulates tissue regeneration, boosts collagen production, and here's the phrase we need to focus on, increases nerve sensitivity.
Right.
It is widely used to help women with anorgasmia, low libido, and even mild stress urinary incontinence.
And, I mean, the logic is sound for those specific issues. It's taking the body's natural healing mechanism, concentrating it by a massive factor, and placing it in a specific area to revitalize tissue that might be thinning due to menopausal atrophy or tissue that is lacking adequate blood flow and nerve response.
Okay, but I have to push back here.
Go for it.
I'm looking at these two concepts side by side, and the underlying mechanisms are totally colliding. If the O-shot is specifically designed to wake up nerves, promote new blood vessel growth, and actively increase sensitivity for better orgasms, isn't that the absolute worst possible thing you could do to someone with MPV?
It seems like it, right?
We just spent the first half of this deep dive establishing that their entire problem is that their body already grew too many nerves.
If we connect this to the bigger picture, you've hit on the exact biological paradox that is being hotly debated in the medical community right now.
So what's the consensus?
Well, what is the actual therapeutic approach when you combine a localized condition of nerve hyperproliferation with a trendy treatment designed specifically for nerve regeneration?
It sounds like throwing premium fertilizer on a garden entirely overrun by weeds.
That's a perfect analogy. According to the clinical reviews on regenerative gynecology, for vulvodynia and NPV specifically, there is currently no scientific confirmation of positive results of this treatment.
None.
None. The medical literature clearly states it remains a potential opportunity that some clinics are exploring off-label, but it is unequivocally not a proven, evidence-based therapy for treating hyperinnervation.
And we actually have a really rigorous study to back up that skepticism.
Yes, we do.
It's a trial published in the Journal of the American Academy of Dermatology. Now, to be clear, this study wasn't looking at MPV specifically. It was investigating a different, painful, inflammatory vulvar condition called lichen sclerosus.
But the way they designed the study tells us everything we need to know about how PRP interacts with inflamed pelvic tissue.
Exactly.
The design is what makes it so valuable. This was a randomized, double-blind, placebo-controlled trial. That is the absolute gold standard for medical research.
Why is the placebo so important here?
You must have a placebo group, especially when studying any kind of pain condition, because the psychological placebo effect, the brain convincing the body it feels better simply because it received a treatment, can skew the data massively.
Okay, so here is how they set it up. They took 29 women with biopsy-proven active lichen sclerosus. 19 of them received the real PRP injections following the O-shot protocol.
Right.
10 of them received placebo injections, which was just plain inactive saline. And because it was double-blind, neither the patients receiving the shots nor the doctors injecting them knew who was getting the real PRP and who was getting the fake saline.
And what was their primary endpoint? Like, how did the researchers definitively measure success without just relying on patients saying, I feel a bit better?
Well, they relied on hard physical evidence. They looked at the tissue under a microscope. The primary endpoint was a measurable reduction in histopathologic inflammation on pre- and post-treatment biopsies. They wanted physical proof that the cellular inflammation was actually healing.
And the final results?
Out of the 19 women who got the real concentrated PRP, 5 had microscopic improvement in inflammation, 10 had absolutely no change, and 4 actually got worse and had more inflammation.
Wow. And the placebo group?
Here's the kicker. Of the 10 women who got the fake saline injection, 5 had improvement, 4 had no change, and 1 got worse.
Unbelievable.
Right. When they ran the math, statistically, there was absolutely no significant difference between the PRP group and the placebo group. The authors concluded that, based on this rigorous biopsy data, autologous PRP does not adequately treat this inflammatory vulvar condition.
That is a highly clarifying piece of evidence. It tells us that while PRP might be brilliant for treating a torn tendon in sports medicine or for aesthetic facial skin rejuvenation, the highly specialized vulvar tissue behaves very differently.
Especially when it's already inflamed.
Exactly, especially when chronic localized inflammation or nerve dysfunction is the root cause.
So if a listener is sitting there dealing with the daily burning, stabbing pain of localized NPV, and they see a flashy clinic ad for the O-shot promising to fix all forms of pelvic pain and dysfunction, what is the actual scientific takeaway here regarding the therapeutic approach?
The core takeaway is that the therapeutic approach must be dictated by your specific underlying biology, not by a wellness clinic's umbrella marketing materials.
Right.
The O-shot has a valid place in medicine. It can be a great option for conditions that genuinely require tissue revitalization like menopausal vaginal atrophy, where the estrogen drop has caused the tissue to thin out, or for decreased libido where the sensory pathways actually need to be woken up.
But for a patient diagnosed with NPV,
Using PRP for localized NTV, a condition explicitly defined by hyperinnervation and an overactive local renin-angiotensin system producing nerve fertilizer, is highly experimental and biologically risky.
risky because of the growth factors.
Yeah, introducing massively concentrated growth factors into an environment that is already proliferating abnormally could theoretically exacerbate the nerve sensitivity. It is definitively not a proven first-line therapy for pain relief in this context.
So if a patient with NPV really wants to try regenerative therapies, maybe they're dealing with mild incontinence on top of their pain and want to try the O-shot for that, they can't just skip straight to the centrifuge.
Absolutely not. The therapeutic approach for an NPV patient considering something like the O-shot must be aggressively multimodal.
Meaning they have to tackle the pain first.
Right. You have to treat the underlying nerve overgrowth first. You have to use the traditional treatment ladder, starting with the overnight numbing creams to break the pain loop, moving to the neuromodulators like Botox to cut the substance P microphone cord, or even undergoing the vestibulectomy surgery to calm or remove that hypersensitive 10x nerve web.
And then, maybe after that.
Only after the severe pathology of the NPV is medically managed and silenced should anyone even consider introducing regenerative therapies that are designed to wake up sensory pathways.
So what does this all mean? We started this deep dive talking about the comfort of a clear X-ray, and we ended up down in the microscopic world of overactive immune cells, misfiring nerve endings, and rogue blood pressure peptides.
We really went down the rabbit hole.
We did. We moved from the agonizing physical reality of having 10 times too many pain nerves packed into a highly sensitive area to the fascinating, but currently unproven, application of blood-spinning PRP therapies for this specific type of pain.
It's a journey that really highlights the absolute necessity of precision medicine, particularly in women's health, where pain is so frequently generalized or dismissed.
It highlights why you have to relentlessly advocate for yourself and why you really need to understand the actual mechanical biology of your symptoms.
Couldn't agree more.
A trendy, expensive, out-of-pocket treatment that works absolute wonders for your best friend's low libido might rely on the exact wrong biological mechanism for your unexplained pain. You have to know exactly what kind of fire you are fighting before you decide what kind of liquid to throw on it.
That's a highly practical way to frame it. And as we wrap up, this research raises a profound question, something for you to mull over long after this deep dive ends.
Oh, lay it on us.
Well, we now know that in NPV, local immune cells in the renin-angiotensin system can accidentally miscommunicate and command the body to sprout a massive, painful web of new nerves in one specific millimeter of tissue.
Right.
It begs the question, What other unexplained, invisible chronic pain conditions in the human body, from mysterious fibromyalgia to intractable lower back pain, might not be generalized wear and tear? What if they are just highly localized, miswired nerve clusters identical to what we see in MPV, just waiting for medical science to find the right cellular off switch?
Wow, that is a wild thought. Just because you can't see the broken bone on the x-ray doesn't mean the alarm isn't very, very real. Keep asking questions, keep advocating for the biology of your own health, and keep diving deep. We'll see you next time.